Okay, welcome back. It's time for our second lecture on the Vent Online course. This lecture is going to be about non-invasive ventilation. Again, this is Ahmed Gamal Sharif, and I hope you enjoy this. So, we're going to try to cover the definition, types of non-invasive ventilations, principles behind them, indications and contraindications, also benefits and disadvantages, and we're going to try to lightly touch base on the evidence base in practice. So let's start with the definition. What is non-invasive ventilation? It's basically the delivery of ventilation via a non-invasive route. So what does that mean? So either, as you can read here, it's either you deliver the ventilation as a positive pressure ventilation or negative pressure ventilation via either the upper airway for positive pressures or the chest walls for negative pressures, without having to use any invasive artificial airway. So invasive artificial airways can be placed on top of the epiglottis like laryngeal masks, or they can bypass the epiglottis and go down the airway as the endotracheal tube. So if you don't use any of those and deliver ventilation without using these modules, then you are delivering non-invasive ventilation. So what we use nowadays is basically non-invasive positive pressure ventilation, and the types of that are either CPAP, BiPAP, CPAP with pressure support. High flow is actually nowadays not considered as non-invasive ventilation because it doesn't really deliver ventilation. It delivers flow, but it doesn't deliver any pressure that is measured. Yes, there are theories about PEEP, but it's not a measured type of ventilation. So when you add high flow to CPAP, BiPAP, and CPAP pressure support, they are all called non-invasive respiratory support. I know it's all details, it's all nomenclature, but it's a rising nomenclature that is going to be used in articles. You need to be aware of it. So, what is CPAP as our first non-invasive module? CPAP is continuous positive airway pressure, and that basically equates to PEEP, which is the positive end expiratory pressure that you expect to keep the lungs open. So if your natural PEEP is not enough and your lung is going down, collapsing and not being really well recruited, then maybe if you push the PEEP from here to there, then that is getting you in a better point for, to open up the lungs. And basically, as you can see on the curves here, we are dealing with the same curve that we talked about in the first lecture, where if you imagine that you're starting from this point, then you're starting from alveolar collapse all the way to a lower inflection point where the lungs get the best benefit of pressure against volume and goes really well up to the upper inflection point. So the idea of applying CPAP is to go from where alveolar collapse is happening to get in above the lower inflection point with a certain amount of PEEP, or at least closer to it. And this is basically what you're expecting to have as breathing around the CPAP you're delivering or the PEEP you're delivering. Basically, the patient breathes just around it. So it still is a normal pattern of breathing where negative pressure gets you inhaling air, while positive pressure pushes air out depending on the chest wall driven pressure. Okay, so in that case, what am I expecting to achieve with PEEP? What's the benefit? Why am I using PEEP or CPAP? What's going to happen? Well, as you improve the lung condition and get less areas being under the alveolar collapse element, then by opening up more of the lung space, then you're achieving more functional residual capacity. Also, you're decreasing the areas that are seeing less oxygen, which means you're decreasing the internal shunt. If you remember from our first lecture, we talked about it. well, there are areas that are not really well exposed to oxygen. That means that they're getting perfusion, so the blood goes there, but it doesn't extract oxygen and goes back deoxygenated, which means there is some level of internal shunt as a criteria, because it's like you've got mixed blood at the end of it. Basically, when the functional reserve capacity goes up and the shunting goes down, your oxygenation goes up. You're also adding improvement to the compliance, because if you look again at the curve that we talked about, you're above the inflection point, which means you're getting the best benefit of pressure generated volume, which means that you're going to get less work of breathing. So generally, CPAP goes with principles that setting the PEEP helps with reliable recruitment strategy. It improves the compliance and the VQ mismatch, or the internal shunting. Stands against further atelectasis, so it is a protective measure that you don't get further atelectasis, and can be delivered by different modalities and different machines, which makes it more of a pragmatic approach. Now we can build up on that with and go with the principles of BiPAP, or bi-level positive airway pressure, which are also the same as the principle behind adding pressure support to CPAP, but with limited differences that we're going to talk about right away. So basically the principle here is, if this is where your normal breathing is, which means your lung is mostly shut down, then if you add CPAP, this is where you are. You're still not at the most brilliant bit, and that is like peep of 10 in this diagram. Then maybe if you're not achieving the best oxygenation and you need more pressure, but you still need the patient to breathe and be able to get chest wall movement, then maybe if you go with what you would expect from a ventilator, but without invasive ventilation, which is having a delta P driven by your machine, or having like a pressure gradient that goes with pushing air in and then allowing for air to go out, then that basically should improve your ventilation. So if your oxygenation is not brilliant and if your CO2 are not brilliant, then maybe adding that would improve things. So basically, this is what is expected from BiPAP. You add higher pressure that would push oxygen and air in, and then allow for an exhalation or expiratory phase, then push again, allow for expiratory phase. These bits are basically where if the inspiratory time is long enough, the patient would be expected to still breathe on their own around these pressures, and then go down again. What's happening here is, if your patient is not really having a good respiratory drive, then you're giving them breath, which should improve your ventilation. But also, you're adding higher pressures with delta P's that should improve your MAP, or mean airway pressure, to be above the level of CPAP while still pushing breathing in. That can be seen again here. So normal breathing is down, CPAP is here. Then if you add a bi-level pressure, then you've got breath that you're pushing in with better quality, and which would improve your CO2 ventilation, because you also can add rate or improve the tidal volume that is generated. And also with that, you're improving the MAP, which is improving oxygenation. So you're getting two outcomes rather than one. The difference between BiPAP and CPAP with pressure support is basically the mechanism of how these breath and how that top pressure is being given from a cycling point of view, where the BiPAP is generated by a set rate. You set a rate and that rate is driven. So if you set a rate of 20, then you're going to give 20 breath. If you set 40, then you're going to give 40. The CPAP with pressure support basically depends on the patient being the triggering and the cycling point. So basically, the patient starts breathing, the machine picks it up and delivers the set pressure, and the inspiratory phase ends with the patient exhaling anyway. So it just depends who's triggering. Is it set by the machine, and who's ending the breath? Is it also set by the machine, or is it set by the patient? Right? So according to what we said, basically what we're expecting from BiPAP is to support inadequate respiratory drive. So if the patient is not really having the a good respiratory rate or respiratory drive because they're a bit lethargic, or maybe a baby that has been extra premature and now is having apneas, then maybe that would help things going forward. Also, it increased the MAP, as I said, and improved oxygenation by adding a top pressure point. It improves minute ventilation by improving the tidal volume and the rate. And it's the last resort before intubation in some certain cases. But it also facilitates high-risk extubation. So if you're extubating a patient and you're not really sure about their drive, maybe coming out of sedation, or you're not sure about their airway or their ability to maintain their drive after being extubated, then this is a good mode for extubation that would sometimes protect you from re-intubation. Okay. So we said something about how pragmatic CPAP is from the fact that it's got different ways to apply and different interfaces. These are just examples of how you can deliver PEEP or CPAP on different ways. So on this left hand side picture, you can see that there are nasal prong CPAP here, and then the connections go into an underwater chamber, along with that arm being connected to the humidifier that you would get with any ventilation set, and that is all connected to an oxygen blender. So that oxygen blender basically gets a set amount of oxygen with set flow, goes into the humidifier, delivers humidified oxygen, and against expiration, against breathing out, you keep a pressure by having the water chamber not allowing for the air to go out without having some pressure against it. And that is how basically bubble CPAP is all designed. Then if it's not bubble CPAP, then basically if you're using a machinery, then like depending on a completely artificial machine or a set machine, then basically it depends on valves, and the valves are how you control the pressures. And the simplest way ever to deliver PEEP is usually via your bag valve mask modules, where there's usually a valve to keep a set pressure delivered to the patient, or if you're using an AirST piece, then that would be, well, without measuring, but would allow you to deliver some PEEP. So there are different ways to deliver PEEP or CPAP to keep the lungs open as much as you can. Then interfaces that you apply to the face can be also different. So they can go from nasal masks to nasal prongs to bigger nasal masks, or nasal plus mouth covering masks, Venturi mask, or even helmets. All of these interfaces can be used. So what are we aiming to achieve then with non-invasive ventilation generally? If we're talking about the whole set of non-invasive ventilation, we are aiming to improve oxygenation as a main theme, because it's PEEP or pressure or CPAP is mainly there to improve your lung recruitment. If you add BiPAP to it, then you're trying to improve ventilation or clear CO2. You're also trying to improve the work of breathing, as we said, by improving the compliance. You're trying to improve the lung functions generally by improving the residual capacity. You're trying to support the airway, support the heart. Supporting the heart basically comes via lots of mechanisms on this account. You can look that up on our free lecture about cardiopulmonary interaction. Then you support neuromuscular drive as well, which basically is what you expect from BiPAP on this account, not from CPAP. So if a patient has got neuromuscular disease and doesn't have a lot of chest respiratory muscle power, then you're trying to support that using BiPAP. So as we said, the main point is improving oxygenation. Okay, then when are we expected then to use non-invasive ventilation? Well, mainly, as we said, if we were trying to improve oxygenation, then you should use it when there is hypoxia. So when you've got respiratory failure type 1. It's also got lots of evidence to support its use with obstructive small airway disease, like in bronchiolitis and asthma. Cardiogenic pulmonary edema is another reason where you try to apply more pressure to basically not allow for a flush or a flood of of blood showering the pulmonary beds, pulmonary vascular bed. It's useful as a step down after extubation, and we kind of hinted on that, and there is also more evidence to support that. It's good to tackle increased work of breathing. It's obviously very useful with obstructive sleep apnea, tracheomalacia, chronic lung disease. Again, because it supports the heart, as we said, is useful in heart failure. Sometimes we just use it with patients heart failure where we just put them on CPAP, and that's mainly for left ventricular support. Scoliosis and abnormal thoracic cage, where sometimes the natural drive doesn't really help with delivering or sucking the air into the disadvantaged areas of the lungs. So sometimes pulse pressure, PEEP, or ventilation can help with that. Again, with hypoventilation syndrome, where you're using BiPAP to help with the respiratory drive, or neuromuscular disease, as we said, where BiPAP can help with the respiratory capacity. Okay, then when should we not use it? What are the contraindications of non-invasive ventilation? Well, first of all, a comatose patient, that's an absolute contraindication. Don't put non-invasive ventilation on a comatose patient. They can aspirate, they can basically keep going down without you getting the best of it. If they're comatose, maybe they're not even maintaining the airway, so you're not really securing the airway in this scenario. If there's cardiac or respiratory arrest, again, same principle, I guess. Facial deformity, I guess that's self-explanatory. And encephalopathy, which goes again with disturbed conscious level and being comatose. Relative contraindications would be other reasons that might be a bit controversial sometimes and sometimes more clearer. So acute hemodynamic instability, if there's an acute hemodynamic instability and you're not really sure that it's coming from just basically a left ventricular problem where you need to support the left heart, maybe you should just not rush into non-invasive ventilation until you achieve stability. GI bleeding, again with risk of aspiration, upper GI surgery, because again you can basically push a lot of air into the upper GI, and that would sometimes compromise the surgery. Status epilepticus is a bit controversial, but it goes with the idea of losing consciousness and not securing airway in some instances. Upper airway obstruction, because if there's upper airway obstruction, then most of what you're delivering is not really getting there. High risk of aspiration, as we said. Mask discomfort and uncompliance can be sometimes a relative contraindication in some scenarios. And that goes forward to talking about disadvantages and complications when we're talking about non-invasive ventilation. So the first disadvantage is sometimes it's not reliable as a delivery method because you can have lots of leaks around the interface itself, around the face, which means you're not achieving the pressures you're targeting. You can also cause pressure injuries by the interface if you try to diminish the leak and keep things really secure on the face. And you can see that that actually is the most common complication of non-invasive ventilation, where you can try to deliver the best pressure by keeping the interface really secure in the face, really tight for long periods without a break, and then basically what you get is a break in the skin itself. Agitation dysynchrony is caused by how tight the interface of the face is and how PEEP is not really comfortable. And then, as you can see in the picture, gastric distension can be very remarkable, and that in a baby can compromise ventilation. So rather than recruiting the lung, you're just adding intra-abdominal pressure that pushes against the diaphragm back, and that is also adding to lots of agitation, lots of dysynchrony, and that's also a factor that can add to the next complication, which is aspiration. So if you don't have a good NG tube that is allowing you to suck a lot of air out and getting a relief of the abdomen, and you notice that the abdomen is bloating, then maybe this is the point where you think, I can't go forward with non-invasive ventilation and I might need to intubate if the child can't be weaned off it. Pneumothorax, as any positive pressure ventilation module, even if it's invasive, pneumothorax is a complication that can happen anyway. And low cardiac output can happen due to increased intrathoracic pressure and intra-abdominal pressure as well. So that just affects basically the venous return. So just be careful when you're looking for these complications. Okay, then how can I identify that the module is not working, the non-invasive ventilation is not working, and I should possibly intubate? So if your respiratory failure is getting worse and you're not winning, obviously, and that is obvious on subsequent blood gases, if your FiO2 requirements are climbing rather than getting better, so you're going above 60% of FiO2 for longer than 4 to 6 hours, it's a good cut line. If the work breathing is getting worse rather than better, or if the patient has got persistent discomfort and you're not really managing to apply the module in the patient and getting the benefit of it, then these are points where you could possibly just think about maybe I should actually intubate this patient and go to invasive ventilation. All right. So let's talk about some evidence base, and this is a very important study or trial to look into. First ABC trial was a multi-center big trial in the UK that was conducted recently and published recently as well, and basically had two arms. One of the arms was called the step down arm and the other one was called step up arm. The step down arm compared high flow against CPAP as a step down from invasive ventilation. So if you're extubating a patient to high flow and extubating another patient to CPAP, what are the chances that high flow is not really inferior to CPAP as a module? On this arm, high flow actually failed to meet the criteria of non-inferiority. So basically high flow was inferior to CPAP as a module of respiratory support post extubation, and that was basically the main message coming from this arm. And you can see the median time of liberation from respiratory support as a median or an average time in comparison. So high flow average was about 50.5 hours, while CPAP had 42.9 hours to be for the patient to be liberated from respiratory support when used after extubation. On the other hand, when they compared high flow to CPAP on the step up arm, which basically means that you're using a high flow against CPAP as a first module as a first respiratory support module to support the respiratory functions of patients coming with acute respiratory illness, high flow in this occasion managed to show non-inferiority to CPAP. So basically, if a patient, let's say, comes with bronchiolitis or asthma or pneumonia or whatever, and they have acute respiratory illness, and they and you put half of them on high flow and half of them on CPAP, basically high flow didn't show worse outcomes in comparison to CPAP. So they were comparative on this occasion. So, and that was called the step up arm, basically. And just adding to some of your input about research and studies, these are a couple of studies that I have been honored to be a part of. So non-invasive respiratory support during pediatric critical care transport. That was a retrospective cohort study that showed it was really safe to use non-invasive respiratory support during critical care transport. This is a study that I started down in Cornwall in southwest of England, and it talks about safety of non-invasive respiratory support on the pediatric wards. And again, it shows that with good training and good approach, you can deliver non-invasive ventilation and non-invasive respiratory support on pediatric wards without needing to shift the patients into ICU, and that would be still safe. Thank you very much. If you've got any questions, please leave them in the comment section and we're going to come back to them, or send them to us on our Facebook Messenger, and we're also happy to reply. Obviously, any feedback is highly appreciated. Thank you very much.